This presentation will look at the anatomy and biomechanics of neural structures. We will then look at general assessment and treatment guidelines using the neurodynamic principles. Michael Shacklock first wrote a paper on neurodynamics in 1995 with the purpose of integrating the mechanics and physiology of the nervous system in the treatment of neuromusculoskeletal disorders. When we look at neurodynamics, we must consider the physiological and mechanical functions of the neural structures. Looking at the physiological function of the neural structures, we can see that with an injury to the nerve, either by compression or elongation, this will impede the intraneural blood flow, impulse conduction, and axonal transport. The peripheral nerve has layers of connective tissue that surround and protect the axons. The outermost layer is called the mesoneurium. The mesoneurium is loose areolar tissue, and the blood vessels enter the nerve via the mesoneurium. The mesoneurium is intimately associated with our fascial system, and this tissue provides a loose framework so the nerve can slide. Another look at the connective tissue of the peripheral nerve shows the epineurium, the perineurium, and the endoneurium. The epineurium is the outermost connective tissue investment that surrounds, protects, and cushions the fascicles. Its collagen bundles are arranged along the longitudinal axis of the nerve. Underlying the epineurium is a layer of flat cells called the perineurium, which form a complete sleeve around a bundle of axons. Perineurial septae extend into the nerve and subdivide it into several bundles of fibers. Surrounding each such fiber is the endoneurium. The endoneurium forms an unbroken tube which extends from the surface of the spinal cord to the level at which the axon synapses with its muscle fibers or ends in sensory receptors. Nerves are bundled along with blood vessels, since the neurons of a nerve have fairly high energy requirements. Within the endoneurium, the individual nerve fibers are surrounded by a low-protein liquid called endoneurial fluid. The endoneurium has properties analogous to the blood-brain barrier in that it prevents certain molecules from crossing from the blood into the endoneurial fluid. In this respect, endoneurial fluid is similar to cerebrospinal fluid in the central nervous system. During the development of nerve edema from a nerve injury, the amount of endoneurial fluid may increase at the site of irritation, and this extra fluid can be visualized using an MRI. With nerve injury, the increased endoneurial fluid is contained by the closed compartment of the perineurium surrounding each fascicle. This will cause positive endoneurial pressure. The edema can only spread longitudinally. This will lead to scarring and will diminish the capacity of the nerve to elongate. Neural fibrosis is the end stage of the nerve injury process. We're now going to look at axonal conductivity. If you have an ischemic insult, it will result in a nerve injury. And an ischemic insult can happen after prolonged compression, elongation, or even just a complete physical disruption of the nerve. The different types of nerve injuries that are seen are neuropraxia, axonotomesis, neurotomesis, and a root avulsion. We can test axonal conductivity, as you know, in our scan with our reflexes, sensation, and key muscle testing. Neuropraxia is the least severe form of nerve injury with complete recovery. In this case, the actual structure of the nerve remains intact, but there is an interruption in the conduction of the impulse down the nerve fiber. Most commonly, this involves compression of the nerve or disruption to the blood supply. There is a temporary loss of function which is reversible within hours to months of the injury, and the average is about 6 to 8 weeks. So Wallerian degeneration does not occur, so recovery does not involve actual regeneration. Axonotomesis is a more severe nerve injury with disruption of the neuronal axon, but with maintenance of the myelin sheath. This type of nerve damage involves the motor, sensory, and autonomic function of the nerve, and it is mainly seen in a crush-type injury. Neurotomesis is the most severe lesion with the less potential for recovery. It occurs on severe contusion, stretch, laceration, or even local anesthetic toxicity. Not only the axon, but the encapsulating connective tissue lose their continuity. And the last or the most extreme form of neurotomesis is transection, but most neurotometic injuries do not produce gross loss of continuity of the nerve, but rather internal disruption of the architecture of the nerve sufficient to involve the perineurium and the endoneurium, as well as the axons and their covering. Even with a mild nerve injury, impedance to the axonal transport will impact the availability of neurotransmitter at the synapse and nutritive substances to the target tissue. So the retrograde flow signals the dorsal root ganglion on the state of the target tissue and nerve. So the end result of most nerve injuries is neurofibrosis. We are now going to look at the mechanical function of neural structures. The nerve must be able to withstand tension, move or slide in its container, and tolerate compression. The perineurium is the primary guardian against tension. So what happens with the perineurium, it can actually cause cabling of the peripheral nerve. So this allows the peripheral nerve to withstand 18 to 22% strain before failure. The second of the primary mechanical events of the nervous system is the movement of the neural structures relative to their adjacent tissue. And this is also referred to as sliding. There are different types of sliding. You've got longitudinal sliding and transverse sliding. And the function of sliding is to dissipate tension and pressure in the nerves. So what can happen is, if the tension point is in the middle of the nerve, you get sliding of the nerve from its proximal and distal ends towards that site of tension. And this is very protective for the nerve. The third mechanical event is compression. Compression allows the nerve to change shape according to the pressure exerted on it. The clinical values are movements about a mechanical interface. The epineurium provides the padding to protect the axons from excessive compression and gives it their spongy quality. Movement of the joints. If the nerve lies on the convex side of the joint, it is subject to elongation forces. If the nerve lies on the concave side, it is subject to shortening forces. So there's a capacity of the nerves to lend their tissue and slide in the direction of the joint from both ends of the nerve tract. If there's more than one joint moving, this reduces the capacity of the nerve to slide or lend their tissue. The mechanical interface is the tissue or material adjacent to the nervous system that can move independently of the system. So for example, the ligamentum flavum is the mechanical interface to the posterior aspect of the spinal dura mater. The zygapophyseal joints are the mechanical interface to the nerve roots that exit at the intervertebral foramen. The mechanical interface is also referred to as the nerve bed. Some examples of mechanical interfaces are the Achilles tendon is the mechanical interface to the sural nerve. The supinator muscle is the mechanical interface to the posterior interosseous branch of the radial nerve. The neck of the fibula is the mechanical interface to the common peroneal nerve at the knee. The intervertebral disc is the interface to the nerve root as it exits the intervertebral foramen. And also down in the foot, the anterior talofibular ligament is the mechanical interface to the superficial peroneal nerve around the ankle. And of course, our whole nervous system is surrounded by fascia and blood vessels. Some examples of pathological interfaces are osteophytes, which can be found in any joint with osteoarthritis, any ligamentous swelling or scarring, fascial scarring, and blood and edema, which can be found post-traumatic in a joint or a muscle. All these factors will affect the ability of the nerve to slide in relation to the interface. When the mechanical interface moves, it can either reduce the space around the neural structure or reduce the pressure around the neural structure. Closing mechanisms will reduce the space for the neural structure, causing increased pressure. For example, lumbar spine extension and ipsilateral side flexion will do this. Also, if you contract a muscle, it will also reduce the space around the neural structure, causing compression. Opening mechanisms will reduce the pressure around the neural structure, therefore giving it more space. So an example of an opening mechanism in the lumbar spine will be flexion and contralateral side flexion. So the dynamics and the associated sensitivity of the nervous system can be tested. So when we first see our patient, we are going to take a history and listen for things like non-segmental patterns, different symptoms that seem to be linked upon a peripheral nerve pathway, and there can be more like variable locations where the pain may jump around from place to place, but it may be in a line of pain, and they may describe things like burning, pulling, tightness, sort of a heaviness of a limb, or they might feel like they're swollen, and they may have things like AM stiffness, and their symptoms could be worse in the evening, and again it would be associated with a particular nerve pattern. If you have an acute patient, you definitely want to look for antalgic postures where they may be protecting a nerve root. So they could be in an anti-tension position where they may have the shoulder girdle elevated and the forearm in pronation if, for example, it was a median nerve that they were trying to protect. Let's look at some of the precautions to assessment and treatment. If they have any neurological signs, if there has been a recent injury or disease of the extraneural structures such as a dislocating shoulder, cervical instability, or osteoporosis, any time following neurosurgery, especially for a nerve repair, following an acute injury such as whiplash, and diseases affecting the mechanical integrity of the nervous system such as rheumatoid arthritis, AIDS, and diabetes, any sort of inflammatory or infective disorder, and any undiagnosed pain syndromes. So this means that you'll have to be very cautious in implementing your tests, and you will usually have to modify the test initially so that you're not going into the full testing position right off the bat. There are also some contraindications to assessment and treatment of the nervous system. Any recent onset or worsening of neurological signs, cauda equina lesions, and any cord signs, or if they've had a tethered cord syndrome. The examination of the nervous system involves palpation of the nervous system, the active and passive neurodynamic tests, and your manual examination of conduction, which would have been done in the scan. Here are some guidelines when starting your neurodynamic tests. It is often good if you can do an active test first whenever possible. Then you will move on to your passive neurodynamic tests. Make sure you have a consistent starting position and have constant communication with your patient. So ideally it should be performed identically on everyone as part of the scan, and then later on you can actually vary various components of the sequencing so that you can load different parts of the system. When you do your testing, you're going to feel for barriers to movement and note the onset of resistance or if there are any other symptoms. So if the person complains of pain, you want to know the area and nature, and you may reproduce the symptoms, but you may not reproduce the pain that the patient is having. But oftentimes you'll have a positive test may mean that you have more resistance or altered range of motion on one side versus the other. So if you get a positive test, that could mean two things. It could mean that the mechanics of the nervous system are normal, but part of the nervous system may be irritated. And this actually can be just the mechanical interface that's primarily affected. The second scenario would be the mechanics of the nervous system are altered. So this would be a neural dysfunction, where you could either have a tension dysfunction or a sliding dysfunction of the nerve. If the problem is primarily with the mechanical interface, what you will find on your neurodynamic testing is that the abnormalities of the test are less significant than the abnormalities that you would have found in the interface. And you may need to alter the sequencing of the test to really pick up that mechanical interface. And sometimes you'll actually get a painful arc in the neurodynamic test. When it's a primarily neural dysfunction, obviously the test result of the neurodynamic test result will be more positive than if it's just a mechanical interface dysfunction. You have picked up a positive neurodynamic test, and now you want to know what to do for treatment. Just remember that sometimes the signs and symptoms may alter with treatment of non-neural tissues, such as mobilization, exercises, and postural awareness, so that all that may be required during treatment is to reassess the neurodynamic test to see if the person is improving. So in fact, you may not actually give them neurodynamic treatment, but use the test to monitor their improvement. We are now going to look at treatment guidelines for the patient who presents with a pain-dominant state. So this person is very irritable. The neurodynamic test would have shown pain before resistance, so there would have been more of an empty end feel. And what you want to do for treatment in this case is to start in the neurally unloaded positions, and you can use tape for that. So for example, you may tape the scapula into elevation, and you may just educate the patient on changing their body mechanics. You start the neurodynamic movements in neurally unloaded positions, and the movement should be free of barriers and non-provocative, so obviously no pain. You will start moving initially away from the injured site, and you'll mobilize the less sensitive component of the neurodynamic test first. Michael Shacklock has described his progressions for someone who is in the irritable or pain-dominant state. So what you would do is you would start by positioning the person out of tension or away from tension and move them to, again, away from the tension position. So sometimes you actually may even position the affected side away from tension and move the unaffected side actually away from tension. Then eventually you will progress towards positioning the affected side towards some tension, but you will be doing the movement away from tension. And then a further progression as the patient becomes less irritable is you can then start to position them away from tension and move towards some tension. And then lastly, you would position them towards some tension and you would start to move them towards some tension when eventually they have no longer any pain. David Butler describes his treatment progressions as follows. You start with large movements that are better for gliding nerves through tunnels. And then if you start with passive movements initially, you can then integrate active mobilizations. And then obviously gradually over time, if the person can tolerate the treatment, you can increase the number of repetitions, increase the strength of the technique, so you gradually go into more resistance, and then progress the technique over after 2 to 3 treatments just to make sure that the patient is fine with the treatment that you are giving him. If you are seeing someone in a non-irritable state, you're going to pick up on your tension tests that there is resistance before pain. So that means that your technique can go into some resistance, but obviously stop short of pain. If it's a very, very chronic problem, you may go into some pain, but then you want to make sure that the pain stops within a few seconds of unloading the tissue. And if they get any paresthesia, it should stop within 10 to 15 seconds of stopping the technique. Now, if you take up the movement of the affected area first, you can actually better challenge the neural tissues at that site. So this again is for a more chronic problem. And if you mobilize the joint or the interface component of the pathology while neurally loaded, this would be more of an end range technique or end of treatment technique. David Butler describes his approach towards treating mechanical interfaces. You start by mobilizing the interface out of tension, and then gradually you add in some tension in the neurodynamic position. So for example, if you're mobilizing the cervical spine, initially you would do the mobilization with the arms down by the side, but then later on you can then put the person in the neurodynamic position. And of course, if you're doing a neurodynamic treatment, start with the remote component first and do sort of pain-free oscillatory movements. And then you would do more of a gliding or a slide initially, or a neural flossing technique initially, graduating towards more tension type neurodynamic mobilizations. It is usually best to start with your Shacklock uses a level system to select his techniques for assessment and treatment. Most patients would be at a level 2, where the standard neurodynamic tests and treatment procedures, as described earlier, would be used. If the person is at a level 0, that would be when neurodynamic testing is completely contraindicated. At a level 1, the test and treatment are modified so that the sensitive neural structures have minimal movement. This would be in the case when there was a highly irritable condition. An example for the upper extremity at level 1 testing and treatment would be someone with a highly irritable carpal tunnel. The level 1 examination would involve doing the upper limb neurodynamic test for the median nerve without the wrist and hand component. Early treatment would involve sliders that do not involve the wrist movements. An example for the lower extremity would be an acute nerve root compression in the lumbar spine. At level 1 testing, if the patient is highly irritable, an SLR would be performed, but the dorsiflexion would be taken up first at the ankle, and then the straight leg raise would be added. If the symptoms are reproduced, you would just then plantar flex the foot to see if the symptoms decrease, and then stop the test. Early treatment at a level 1 for an irritable lumbar spine would involve just doing dorsiflexion and plantar flexion of the ankle in a neurally unloaded position. So when you have done the standard tests and you do not have enough information to treat, you can then move to level 3 testing, provided the patient has a low level of irritability. So at level 3, the testing involves sensitizing maneuvers to the affected region. So for example, with the carpal tunnel, at level 3 testing, this time the wrist and hand component would be taken up first in the upper limb neurodynamic median nerve test. If you wanted to further test the carpal tunnel interface, you could do fanning and folding techniques of the carpal tunnel in the neurodynamic test position. You would then see what the effect of this would be on the patient's symptoms. So treatment for carpal tunnel at level 3 would involve sliders and tensioners with the wrist component taken up first, or you could be mobilizing the carpal tunnel interface in a neurodynamic position. At level 3 testing for a lumbar nerve root with a low level of irritability, this could involve lumbar spine side flexion away, hip internal rotation and adduction, which would be taken up before you go into the straight leg raise or slump position. So treatment could involve tensioners done in the slump position with lumbar spine side flexion away and hip adduction and internal rotation taken up first before the knee extension and ankle dorsiflexion component are added. Treatment at a level 3 could also involve treating the stiff zygapophyseal joint. And what you could do is first test the joint in the neurodynamic position, and you can do opening and closing maneuvers around the joint. So taking up either side flexion away or side flexion towards. Away would open up the joint and increase the space around the nerve, and side flexion towards would decrease the space around the nerve. So you could do a zygapophyseal joint movement in a neurodynamic position and see the effect on the patient's symptoms. If you found that there was an effect on the patient's symptoms, you could actually mobilize the lumbar spine in a position of neural tension. So what are the effects of treatment? The treatment will increase the blood supply and the axoplasmic flow to the region. You get a mechanical dispersion of intraneural edema. The treatment can decrease the connective tissue entrapment, normalize pressure gradients, and increase the cerebral spinal fluid circulation. If you are taking the level 3 upper or lower, there is a separate Thank you for listening.